Welcome back. In this block, we're going to review the toxicities of these older cytotoxic agents. And as we look at this, there's a lot of them. I think it's important, though, for you to recognize, and we'll emphasize here, which ones are the ones that you need to be aware of as a clinician who's practicing and maybe inheriting a patient on your doorstep with one of these toxicities. You know, which agents cause them, how they present, how we manage them. Okay, so we'll try to focus on the ones that are more pertinent to you practicing, not necessarily in the oncology suite, but inheriting the patient who's just recently gone through or has in the not too distant past gone through chemotherapy. So as we look at these toxicities, we'll try to group them into some logical sequence and then the kind of things you're again going to see in practice. One of the broad ways of grouping many of the toxicities, not all of them, but many of them, relate to what they do to rapidly dividing cells and account for these patterns that we see. So one grouping we'll talk about is GI toxicity. That includes nausea, vomiting, either around the time of administration, right before, or in a couple of days afterwards. We'll talk about that. We'll talk about stomatitis, which is the inflammation of rapidly dividing mucosal membranes in the mouth that's quite painful and a source of infection for patients. We'll spend and probably am most concerned about bone marrow suppression, particularly white blood cell suppression, the risk for infections, and this concept of neutropenic fever. That is a medical emergency. You need to be able to recognize that, and we'll spend a fair amount of time talking about that both here and in class. Sometimes the chemotherapeutic agents we use cause some anemias or red cell suppression, not as commonly as the other kinds of bone marrow suppression, partly because the life of the red cell is longer where the life of the white cell is shorter. So if you're impacting rapidly dividing cells with something that has a relatively shorter duration of lifespan or half-life, white cell, those are going to be more affected. Similarly, platelets are pretty well affected too because platelets' lifespan is fairly short. So we worry about thrombocytopenia and bleeding risk for these patients. When we have a lot of cell rupture, particularly seen in lymphomas, some leukemias, then the release of the intracellular components cause a problem. That's tumor lysis syndrome. We'll talk about that. And we have to kind of think about in the back of our mind that these agents are teratogenic, both for the risk for healthcare personnel and other people who might be exposed to these agents in the course of taking care of patients, and for the patient themselves, particularly for women of childbearing age. But the reproductive risk toxicity may extend to some degree to men as it relates to testicular and sperm cell injury as well. So of all of the toxicities, let's sort of front load what in my mind is among the most serious and consequential and what you will likely see frequently at your doorstep, and that is bone marrow suppression. A lot of the older agents in particular, and some of the newer agents as well, are known to be highly toxic to bone marrow, causing a suppression in one or more of these elements, leading to the risk for infections if it's white cells, bleeding if it's platelets, and anemia if it's red cells. Neutropenia, though, in my mind, is probably one of the most concerning. And we often see this drop in or this bone marrow suppression happening within 4 to 10 days after courses of chemotherapy. And we call that low point in the bone marrow suppression, the most extensive bone marrow suppression, with a low point in white counts or platelets as the nadir, the lowest point. And that usually happens, again, between 4 and 10 to 14 days after therapy. And that depends on the agent, it depends on the type of cancer, the patient, but we're really concerned about that. We worry about calculating someone's absolute neutrophil count. And our expectation is that you will know, presented with a case, that you will know how to calculate an ANC and interpret it. We are really concerned when the ANC falls below 500 in particular for these patients, but even under 1,000 we worry about immunosuppression, significant immunosuppression. And when we have a patient who presents with a fever and immunosuppression, we call that febrile neutropenia. That's considered a medical emergency for which we get on it right away. We don't delay things. We'll also talk a little bit about when and how we use colony stimulating factors to reduce the risk for this neutropenia in patients who are at higher risk for it. Thrombocytopenia is also a problem. When platelets get below 50,000, we're particularly worried about bleeding risk. The lower the platelets get, the more concerned for bleeding we are. So we're also encouraging patients who are at risk for this to use soft toothbrushes to take care whenever we're doing any kind of procedure. Avoiding the drugs that are going to promote bleeding, the NSAIDs, avoid IM injections, those kind of things. And we're really careful about when we use anticoagulants in these patients. Now, what we don't talk about in this block at all is the risk for clots in patients who have cancers, and the risk for the cancer causing increased risk for clot formation and the risk for clots. Are they really patients who are hypercoagulable because of their cancer? So many times we're in the dilemma of someone who's getting chemotherapy who has a high risk for clots, for which we're considering the anticoagulants, and yet they also face with thrombocytopenia. And so we weigh the risk and the benefit of having a clot versus their bleed out risk when they have significant thrombocytopenia. So that's a big concern for us. We also look at anemias, which are less likely with a lot of the chemotherapy, but can happen. Historically, we used to see anemia as either related to chemo or related to the cancer itself commonly, and we would historically commonly use epogen or erythropoietin, and like we would with a renal failure patient, which we talk about in the renal block. Much less common to do that now because the anemias usually aren't that significant in these patients, and there's a risk for using EPO aggressively in these patients as well. We worry about digestive tract injury. Stomatitis is probably the biggest one. We worry about inflammation of the oral mucosa with severe pain, and also the risk for infection because you've got a barrier that's diminished. We worry about diarrhea. We'll talk more about nausea, vomiting as well, both the direct effects from the chemical trigger zone. So the drug itself sort of triggers a message to the brain that this is a toxin. So we're sort of evolved to sort of induce vomiting when we're exposed to a toxin, but also some local irritation as well that could contribute to the nausea and vomiting as well. We'll talk about that. And our management for prevention and treatment of nausea, vomiting with chemo sort of overlaps what we'll talk about in the GI block as well. And then other toxicities, we talk about hair loss, reproductive toxicity, hyperuricemia, which we'll talk about particularly with tumor lysis syndrome. And then finally, as an overview, we'll talk about the local injuries of extravasation of these vesicants, the irritants that they can cause, and then some unique toxicities depending on what the agents are, particularly the risk for heart failure with anthracycline like daunorubicin, doxorubicin, the kidney injury with visplatin, or the peripheral nerve neuropathies associated with vincristine and vinblastine. So let's start with a little more detail about preventing GI toxicity, particularly nausea, vomiting. We alluded to the emetic response as being sort of a natural response to chemo for patients. I think a lot of patients, particularly some agents, are more emetogenic than others. And when I think of, and when a lot of clinicians think of chemo-induced emesis, they really fall into three broad images or three broad groupings. One is anticipatory emesis, second is acute emesis, and third is delayed emesis. So let's sort of unpack this and sort of relate this. Anticipatory emesis is often not dissimilar from patients who have post-traumatic stress, who have nausea and or vomiting when re-exposed to a stressor. So if a patient has a bad experience in a prior treatment for chemotherapy and has a lot of nausea, vomiting with that chemotherapy, when they come back for their second, the third cycle of chemotherapy, before they even get into the building to take their chemo, they have a almost post-traumatic stress reaction, an anxiety-related reaction called almost parking lot vomiting. And we see this a lot in patients who don't get good control of their emesis for acute and delayed emesis. And so really important with each and every course of chemo that we really prevent emesis to the extent that we can. And that's usually in the purview of the oncology team, usually not your purview, but you need to be aware of that. Acute emesis occurs sort of directly related or within the window of time while the chemotherapy is infusing to shortly after, up to the first day. When the chemo's hanging around, it's getting a lot of exposure to the chemical trigger zone or other areas that sort of trigger vomiting. That's kind of expected, I think. What's less expected but happens directly is this delayed emesis that happens beyond 24 hours after the patient's left the infusion suite. And this may be a patient who presents to the emergency department with cyclic vomiting on day 2 or day 3, and you're trying to control that. Well, if you didn't know they had chemo yesterday, your approach may not know to involve the oncologist in that. So you kind of want to be aware that this delayed emesis can happen as well. There are variables associated with all of these, but the patients who have the most trouble with vomiting, particularly anticipatory vomiting, are younger patients or patients who've had a bad experience with that in prior treatments. Sometimes it's seen more with folks who have a history of motion sickness or a gentle stomach, so to speak. If it's women, sometimes there's some data to say that, not consistent. There's high anxiety. If they have a high anxiety sort of purview already, that's a problematic situation for them. And certainly related to the emetogenic potential of the agent or agents they've received in the past or are currently going to receive. The way we prevent that anticipatory is the best thing you can do is first manage each and every course of chemotherapy so they don't have emesis in the first place, don't have nausea and vomiting, manage that. And a lot of prevention is going to happen. The other thing that we typically will do is to look at benzodiazepines like lorazepam. They do a couple of good things, both for anticipatory vomiting and acute and delayed vomiting. They reduce anxiety. But if you remember, benzos also impair memory. And so they make their experience during the chemo infusion sort of a little more cloudy, a little less, memorable, which is an advantage in this case that helps prevent this sort of more stress associated with it. And then all the other things that you're going to do for anybody who has an anxiety state, we're going to look at guided imagery, maybe hypnosis, biofeedback. Distraction is a big one. That during infusion, either with anticipatory or actual emesis, patients are really encouraged to bring something to read. To do video games is a pretty common thing to consider, which is really a distracting kind of thing for patients, and that's actually a good thing. For acute emesis, which can happen quite commonly, depends on the nature of the agent. Some agents are considered highly emetogenic, others are not. And so it's important to do that. And for this next bunch of slides, it is not our expectation that you know which agents cause it, but just be aware that some of them are more emetogenic, cause more emesis than others. So the most highly emetogenic regimens are those that include doxorubicin or any of the combinations of anthracyclines. Carmustine, cisplatin, also associated with it. Those are pretty commonly used sort of agents. And then there are other agents that are more moderate, but still pretty significant emesis, as well listed here. A number of agents that are lower emesis, some that are minimal as well. And then there's sort of the moderate to high risk agent combinations or individual agents for which prophylaxis is recommended, is listed in these kind of tables, and where you don't necessarily need a lot of prophylaxis for a single administration agent. So you don't need to know the detail of that, and that's all managed by the oncologist. But the basic approach to antiemetic therapy is to do multiple strategies to look at preventing emesis in the first place. And it is always easier to prevent vomiting if you catch it early and manage nausea before the patient gets to vomiting. This is true whether you're talking about chemotherapy or anything else. So you're going to look at neurochemical control with drugs. We're going to look at intervening with a number of different receptors that work at different places. in the chemical trigger zone. So you'll see agents that are serotonergic or affect serotonin, affect histamine, dopamine, acetylcholine, and other neurotransmitters. And usually you're going to see combinations of therapies. Most of this is going to be managed by the oncology team. You're not going to be managing it. But as you're aware of it, there's different sort of areas that contribute to vomiting reflex. And if you sort of move backward from the vomiting center, kind of what are the kind of areas that will trigger it and what are the interventions that are going to help reduce it? Well, you'll see in orange here, the benzodiazepines impairing your perception of nausea, vomiting, the histamine antagonists, the muscarinic antagonists, dopamine antagonists, cannabinoids, serotonergic agents can affect the stomach and small intestine triggering as well. And the gastroprokinetic agents like metoclopramide or Reglan can have some effects as well. And so we're going to sort of look at multiple regimens, and you'll sort of see on the next couple of slides examples of those regimens. Again, not our expectation that you are in a position to go through that, just that you understand and appreciate these and know these are the very drugs we talk about in the GI block as well about managing nausea, vomiting in non-chemotherapeutic patients. So the antiemetics, the older agents like promethazine and prochlorperazine, these are older agents that aren't used very much anymore, but occasionally used. They're associated with QT prolongation, extrapyramidal side effects, all the things we saw or that we will see when we talk about them in the mental health block, the antipsychotic drugs. The serotonergic antagonists, though, are very commonly used for preventing nausea early on. They do much better for nausea prevention and treatment before vomiting happens. And ondansetron is probably the one you'll see used most. Low to moderate doses that are used in post-surgical patients, 4 milligrams, 6, 8 milligrams. Not a lot of QT prolongation. But the doses that are used in oncology suites, 16, 24 milligrams, more degree of QT prolongation. So we worry about QT prolonging effects for folks on big doses of these. So if you inherit a patient who's been on a lot of ondansetron or one of these agents coming in, and you're considering using QT prolonging drugs in the emergency room, you have to kind of be aware of that. The antihistamines sometimes used. They're not all that commonly used in cancer chemotherapy regimens, but they could be used. Haldol and droperidol sometimes used, again, QT prolongation. The NK1 antagonists, though, are used in certain regimens more for delayed emesis. Aprepitant, for example, is an agent specifically used in oncology suites. And then finally, the miscellaneous agents have their unique kind of roles of where they fit. And we'll talk about where some of these things kind of sort of fit in the role of things. There's data for all kinds of agents for chemotherapy-induced nausea vomiting, and I don't want to sort of get in the weeds of this, but you'll sometimes see the other antipsychotics used as well. And then as you look at some of the regimens that are listed for highly emetogenic regimens, you'll see that patients will get a certain regimen on day 1 of their chemo before they start chemo. In the first column is, sort of the second column is listed there. And then what they're going to get for their day 2, 3, and 4 of chemo or the days after they've had cycles of chemo. And a lot of patients who get chemo, particularly using the older cytotoxic agents, will come into the infusion suite for a combination of therapies on day 1 and then come back to the infusion suite day 2 and day 3 to get more rounds of their chemo for 3 or 4 days sometimes in a row, and then have 21 to 28 days off of their chemo regimen before they start their cycle 2, cycle 3, cycle 4. And so these antiemetic agents are sequenced in with those cycles of chemo. So I think it's just helpful to sort of let your eyes glaze over these regimens and sort of be familiar with some of the regimens that the oncology team will use, even though you may never use some of these agents. The NK1 antagonist, for example, you'll probably never use, but you may see patients on them lingering for their post-emesis, delayed emesis management. Here's some moderate regimens that include some of the very same drugs. Low emetogenic regimens as well that include some of the drugs we've talked about earlier. And then sort of other sort of antiemetic regimens that are sort of used as part of different protocols as well. Again, not a focus, not that you need to sort of focus on that. Another set of guidelines for emesis are listed by national standards. One is the ASCO standards from the American Society of Clinical Oncology. These get updated periodically. Here's from a couple of years ago what those guidelines are. And again, we don't need to go through this at all, nor do you need to know it, except to know that there are guidelines that continually evolve for the oncology teams about what antiemetics they should use, the nature of the clinical questions that come up, and how these guidelines sort of say how clinicians should manage those things. You add more content and more and more and more. So the last concept with emesis here is the concept of delayed emesis. And this is for folks who get highly emetogenic regimens. A lot of those patients will experience nausea, vomiting on day 2, 3, or 4. And so there's going to be regimens that are either going to use on day 1 very long-acting agents, or to use agents that are administered also on day 2, 3, or 4. Typically, it's on Dancitron, or sometimes on Dancitron with a Prepident, given on days 2, 3, or days 2, 3, and 4. And so we'll see that this is again managed by the oncology team. But when you're inheriting a patient on day 2 or 3, and you're concerned about, QT prolonging drugs, for example, and they're on Dancitron on top of everything else they're on, well, when you go reach for azithromycin or fluoroquinolone, you need to think about QT prolongation as a potential risk for them. So again, all of those things are part of our situation to think about.